We will continue with the deficiency-induced neuropathies, and the next is about the cyanocobalamin deficiency. Now, actually, with the cyanocobalamin deficiency, it's a very rare phenomenon because the liver stores around 4 milligram of cyanocobalamin, which is enough for 3 to 6 years of supply, and hence primary deficiency are extremely rare. And except in strict vegetarians and maybe nursing infants, but manifestations of cyanocobalamin deficiency complicate the presence of malabsorptive disorders. If the patients have a malabsorption pathology, in that condition only the cyanocobalamin deficiency can occur. And the lesions which appear throughout this white matter, they are actually present with the neurological deficit, where there will be a generalized reduction of the white matter, and it can produce a degenerative changes in the nerves. So, as such, a real cyanocobalamin deficiency is a rare phenomenon. Then the next is about the pantothenic acid deficiency, another of the B complex issue. Almost all foods contain this constituent coenzyme A, and it's in the tissues its concentration is about 10 times that of thiamine and 50% of the nicotinic acid. Deficiencies are extremely rare because of the large amount of the storage, as in the case of the cyanocobalamin. But pantothenic acid deficiency can occur in patients with the very chronic diabetes mellitus like conditions, or occasionally it also can occur in the patients with malabsorption pathologies. Otherwise, it may not occur. Certain of the drugs also can affect the pantothenic acid, particularly that antitubercular treatment. It can result in deficiency as such. And the clinical symptoms will be burning food symptoms, again typical of a peripheral neuropathy, and that the daily requirement is around 6 to 10 milligrams as such. Then another of the common condition where there will be a neuropathy, deficiency neuropathy, is in celiac disorders, gluten sensitivity disorders, which we have referred to in the gastrointestinal tract pathology in detail. Now, in gluten in wheat or barley or oats, which can result in damage to the Purkinje cells and other neurons, leading to cerebellar ataxia, myoclonus, neuropathy, and neurologic symptoms. This is one of the common complications of the gluten sensitivity neuropathy. And gluten sensitivity or celiac disease we have discussed in detail in the gastrointestinal tract system in detail as such. Now, the treatment protocol there would be, of course, there is no question of any specific curative treatment. The other way is the diet restriction, gluten-free diet restriction. From Ayurvedic point of view, patients respond well with the Ananda Bhairavi and Mustakarishta in such conditions. Then comes the autonomic neuropathy, another of the common and often neglected condition. It occurs quite frequently. The autonomic neuropathy, where the autonomic nervous system like parasympathetic and sympathetic nervous system functions are affected, and they again could be of three categories: inherited, and in the inherited again it could be familial amyloid polyneuropathy or hereditary sensory autonomic neuropathy, acute intermittent porphyria or variegata porphyria. Now, comparatively, these inherited autonomic neuropathy conditions are rare as such, except occasionally we may see a patients with the porphyria. Rarely we see patients with the porphyria. But majority of the patients whom we see the autonomic neuropathy are mainly in the acquired category like diabetes mellitus or uremia, hepatic disorders. Mainly these two, diabetes and hepatic disorders, are the more common issues. Alcohol, another of the common diseases which are autonomic neuropathy can occur. Then viral diseases like HIV, it also can produce the autonomic neuropathy. Leprosy, that again you see that quite frequently. Even very chronic conditions of rheumatoid arthritis, we may see the symptoms of autonomic neuropathy. The other relative less common causes are vitamin deficiencies. Diphtheria, of course, is almost there now. Patients of Guillain-Barré syndrome, particularly in the acute stage, would have autonomic neuropathy symptoms. Guillain-Barré syndrome we will discuss in detail later in the coming sessions. Ulcerative colitis also, patients of ulcerative colitis also can have the autonomic neuropathy complications. Clinical presentation of autonomic neuropathy would be quite wide varying depending upon the area involved, because autonomic nervous system would be controlling the functions of different areas of the body, and based upon that the symptoms also would be different. Now I have listed these symptoms based upon the clinical presentation, more frequent clinical presentation. Among them, the most common clinical presentation is a facial presentation, where the patient would have a pallor, anhidrosis. The look of a patient, when you look at the patient, the look itself would be looking somewhat what we call as ill appearance. Patient would be having a pale, the sweating would be lesser, and hence the whole face looks like a dry face as such, which is often seen in very chronic diabetic patients where the sugar is not controlled. This is commonly seen. Then another common symptom will be ocular symptoms, where either the patient may have a vision abnormality of different sorts. Patient may say that his vision is having a graying, like the whole area looks smoky, or some of that dull looking like appearance, like these features. Some of the patients may have a blackout symptom, like a sudden temporary loss of vision temporarily, then again they may recover. Or some of the patients may have restricted field of vision, which is called as tunnel vision. Or some other patients may have a hypersensitivity to light, and they may have a difficulty in focusing, like they may not see the distant objects or nearby objects, so on. And dry eye conditions, the lacrimation could be reduced, and the pupillary constrictions or pupillary relaxation may not occur properly. A delayed pupillary response also could be the clinical symptoms of the eye. So in total, the patient is present with the various issues related to the vision, again quite common seen in diabetes mellitus. Then the other symptoms will be cardiovascular symptom, where patient may have a palpitation on erect posture, whereas in the lying down posture it may reduce, and even giddiness also can occur in the erect posture due to incompatibility of the cardiovascular system. In the normal sympathetic or parasympathetic system regulates the blood flow according to the posture, whereas this would be affected, and hence the patient may have giddiness on standing erect posture, or at times palpitation, or a severe palpitation on exertion, much more than the usual. That also is a sign of autonomic nervous system pathologies, autonomic neuropathy conditions. Nausea, tremors, like, or again pre-syncope, they may not have a total loss of consciousness, but very near to that. Tinnitus, headache, chest pain, and shortness of breath. The elderly patient may complain of discomfort in the lower limb. They may not have a proper, or they may have a feeling like there is something extra layer over the skin, thicker skin like appearance, which is also called as coat hanger feeling. And maybe often these symptoms would be aggravated after a heavy food intake. This is very common clinical symptoms as such. Then the gastrointestinal symptoms are also quite common, and very common symptoms are either constipation or episodic diarrhea or early satiety. These are the very common clinical symptoms of autonomic neuropathy involving the gastrointestinal tract. Then in some other patients it could be increased gastric motility, where the patient may have an urge for defecation immediately after the food, dysphagia or bowel atony, that movement of the intestines would be reduced, or bowel incontinence also, or dilatation of the stomach in the diabetes mellitus, which may cause food stasis and subsequent vomiting. Or salivation may be reduced, or sense of taste also would be reduced, or patient may have a feeling of semi-consciousness or feeling of loss of consciousness during micturition or defecation. Then renal symptoms also can occur, which can be nocturia, that's the more urine, more frequent urine at night, urgency of the micturition, frequency of micturition could be enhanced, even there could be uncontrolled micturition at night, which is often confused with the prostatic hypertrophy conditions in patients with the diabetes and old aged patients, like it's common. Sexual symptoms like impotency, loss of ejaculation, retrograde ejaculation in men, or inability to achieve orgasm in females or both sexes, it also can be seen as the parasympathetic or autonomic nervous system pathology. There could be abnormality related to the sweating, like either excess of sweating or maybe absence of sweating, reduced sweating, like, or there would be what we call as a compensatory hyperhidrosis or gustatory sweating. Compensatory hyperhidrosis is when a patient goes from a cold area to the warm area, there will be sudden and severe sweating. Gustatory sweating is a sweating produced after consumption of the food, or the patient may have a abnormality of the temperature regulation, which is not so common. Maybe in patients with the severe complications it can occur, where the patient's body temperature may be reduced and the shivering can occur, and or the patient may have hyperpyrexia, very high fever also in autonomic pathologies. Autonomic neuropathy presenting with the thermal changes like hypo or hyperthermia would always have a poor prognosis. Then the patients may have a sort of peripheral neuropathy, where the patient may not be able to have a proper sensation. Itching could occur. Patient may not be able to feel the position in which he is there, like that dysesthesia. Or allodynia is where the patient would have an improper movement, cannot just measure the movements, so his steps would be altered. Or there could be more severe pain-like symptoms. The symptoms which usually occur are aggravate at night and dry skin, and it's signs like peripheral ischemia, where the hairs in the distal area could be reduced, nails become bitter, pallor or cold feet-like symptoms, which are the signs of ischemia, which occur due to the spasm of the blood vessels. Spasm of the blood vessels is due to this excess of sympathetic stimulation which occurs in the body. Then respiratory symptoms like where the patient may have impaired bronchomotor tone, that's the air resistance would be varying, which is commonly seen after you do the investigations. Otherwise, and investigations particularly done in that way would be by giving a cholinergic stimuli like usually these phenylephrine is given, and then the respiratory these volumes are assessed in that condition. So it's more of investigatory findings than really the clinical symptoms. Particularly these are important to the patients who are in ICU, that respiratory symptoms, temperature symptoms are suggestive of more severe complications, and they are important in the ICU conditions. Like clinical examination of a patient suspected to have the autonomic neuropathy, the examination should be in detail. You have to examine the palms, soles and axilla for that sweat, excess of maybe the absence of the sweating. Pupillary responses are quite important for the light and accommodation. A sluggish pupillary response is one of the important signs, or it could be the Horner syndrome, where if you touch the face on any side, there could be a reduced sweating over the area, as well as the pupillary size would be reduced on that area, sudden, or maybe the ptosis, the palpebral movements could be affected. Oral cavity also can be is one of the features, one of the areas which can give you some clue about the possible autonomic neuropathy, where the patient have multiple caries or the whole stomach, this oral mucosa could be replaced by a keratinous tissue. Conjunctiva and cornea for excessive scratches or signs of trauma due to xerophthalmia, like because of the dry eye pathology. The lower abdomen for detection of the distended bladder. These are the important clinical examination. They usually, for assessing this autonomic pathology, because of the multiple symptoms and the possibility of different conditions it can present with the similar symptoms, a composite autonomic scoring scale is used, that's called as a CAS or composite autonomic scoring scale. Particularly these are important in patients in ICU conditions. Even otherwise, even in routine conditions, these are important. Based upon these symptoms which we have discussed, the scores are given. Like if a patient has orthostatic intolerance, like giddiness on erect posture, you give 10 points. Vasomotor responses like the ischemic changes periphery, the 6 points. Secretomotor, like where the secretions of sweat or sweat glands, etc., then 7 points are given. Gastrointestinal symptoms, 28 points. bladder 9 points, pupilomotor 15 points. Depending upon intensity of these symptoms, these points may vary, and based upon that, the severity of the autonomic scoring, autonomic abnormality can be made out. Now, as far as the management is concerned, there is no uniform symptom management as such. The treatment would be in the contemporary system. Treatment would be based upon the set of the symptoms which are seen. If the patient has a cardiovascular symptoms then the symptomatic treatment with the AC inhibitors are given or beta blockers. I would prefer to use arginarista in such patients with the cardiovascular symptoms produced due to the autonomic pathology, very often seen in old aged patients or diabetic patients, where the ECG may not show some significant abnormality, but or at times it could be even patients may have a ischemia without any obvious clinical symptoms of pain, and patients who have that giddiness on the right posture, these patients respond well to arginarista. Patients with gastrointestinal tract symptoms, where the patient may have diarrhea or so on, in such conditions, the contemporary system is simply antidiarrheal drugs like loperamide is prescribed or laxatives are prescribed. But I would not prefer that. I would prefer Agnitundi as a better treatment, and the patients respond very well. Gastrointestinal tract symptoms, they respond very well to the Agnitundi. Genitourinary symptoms like erectile dysfunctions or mixed bladder pathologies, in that condition, the contemporary system, there is no specific treatment, but sexual stimulants like sildenafil or psychological counseling, etc., are suggested. But patients may respond moderately well to Chandraprabha. Then patients who have a metabolic pathology like autonomic where the patient may have that sudden development of the hypoglycemia and feeling like a hypoglycemia like symptoms, there the better treatment would be Kumariasavar. Then pseudomotor sweating, of course there is no specific treatment for that. In the contemporary system they do give vasodilators as a treatment, which I generally don't consider that. So that's about the peripheral neuropathy conditions. Now the next variation of the peripheral neuropathy would be about the carpal tunnel syndrome. Carpal tunnel syndrome is another of the very common condition which we see clinically. It's based upon the anatomical fact that the median and ulnar nerve, they pass through a tunnel-like structure covered by a carpal tunnel in the wrist area, and because of this, the median nerve has a high chance of getting compressed. Now, this is one of what we call as a compartment syndrome. Because of the compression of the nerves, the lesions would occur. This is exactly what it was believed earlier, like it's due to the compression. But now the hypothesis is slightly different. It suggests that there is a abnormality of the vascularity. The blood flow to the compartment is reduced, the vascular compartment will be compressed, and hence there is a neurological deficit. That's the current theory. Anyway, the basic issue is there is a mechanical compression of the carpal tunnel. Whether it produces the compression of the nerves directly or the nerve damage is a complication of the vascular compression, these are the issues of difference of opinion. Of course, that's not a major issue. But incidence is quite common, and incidence is increasing every year. Now, from throughout the globe, this carpal tunnel syndrome has become one of the major issues. Reason is supposed to be due to a relatively higher body weight. The body weight of the population throughout the globe is increasing, and it's said that in the past 15 years, the body weight has increased by around 45%. Average body weight has increased by about 45%. So almost 1.5 the more weight than the previous generation. This is what's believed to be. And because of that, the incidence is supposed to be raised to around 150 cases per 1000 subjects per year, which is the rate of increasing, and it can even reach up to a level where 500 cases per 1000 subjects, like in high groups. Right? So that means 1 in 2 persons may have this carpal tunnel syndrome. The factors which can produce the autonomic pathology or this carpal tunnel is, as I said, The current theory is like there is a venous stasis which results in demyelination, axonal degeneration. This is the current theory. Earlier, it was believed like there is no question of venous issue. It was directly demyelination of the axonal degeneration was the earlier theory. Of course, as I told you, that doesn't make much of a difference. And usually, sensory nerves are affected first, then the motor and autonomic nerves will be affected. The risk factors are listed as it may be a trauma, previous trauma. Genetic factors are one of the issues. Genetic factors, certain of the people would have a tendency to have the autonomic nervous system, which is also called as a square wrist symptoms. Patients who have abnormality of the shape of wrist, I will show you some of the images there. Then patients who have rheumatoid pathology, hypothyroidism is believed to be one of the causes. Exactly how hypothyroidism results in a carpal tunnel pathology is not known, but the one of the hypotheses is that because of the hypothyroidism there is excess of fat deposition in the area which produces a compression. But majority of the patients of hypothyroidism do not show that fat deposition, but carpal tunnel syndrome symptoms may occur. So that's one of the issue. Diabetes mellitus, any of the condition which results in fluid retention like pregnancy, menopause, renal failure also is one of the causes for the carpal tunnel. One more of the causes is the repetitive use. Those who use the mouse regularly in the system, working in the system, software engineers and so on, they have a high chance of this. The other demographic factors are, it's common in old age, more common in female sex, patients who are obese, increased body mass index. It's one of the important causes. As I said earlier, it's in the recent increase, the major cause for the increase in the graph of carpal tunnel syndrome occurring has a very high peak, like, and that's due to the increase in the body weight. Then square shaped wrist, which is a genetic one, or patients who have a short stature, they have the chances. Usually it occurs on the dominant hand. Those who have right hand as dominant, they tend to have the lesion in the right hand, whereas those who have left hand as the dominant, it occurs more frequently in the left hand. It's more common in white population than the black population, but in India the incidence is increasing and we see lots of cases there. The typical symptoms and signs are, the initial most symptoms will be a numbness and tingling in the median nerve area. The location is very typical. Initially it's on the palmar side, the thumb and the 2.5 fingers on the other side. They are the more initially affected. Initially it presents with the numbness, and because of the numbness the patient may feel like the patient is not able to do the fine functions. The numbness exactly ends on the dorsal side, exactly at the mid-phalangeal area, doesn't extend to the whole of the hand in the dorsal side. So that's more important. A numbness which is present in the palmar side extensively, but on the dorsal side limited only to the tip of the fingers. That's the common phenomenon. And gradually it results in motor symptoms where there will be weakness or even the wasting of the muscles, where, as you can compare in this image, typical thinner group of the muscles will become wasted, and that's a sign of an advanced carpal tunnel syndrome. The clinical signs, there are many methods of examination of the carpal tunnel, and the tests are of different categories. Among them, some of the tests are considered to be more sensitive, some are less sensitive. But among them, the oldest of the test sign to confirm the carpal tunnel sign is a Huffman tunnel sign or tunnel sign, where you tap over the median nerve in the carpal tunnel area, which produces a tingling sensation over the area of the distribution. So if you tap over at this area, patient may feel a tingling sensation. This is the most common and almost seen in majority of the patients as such. According to the contemporary neurology textbooks, this test is not very sensitive. Many of the neurological new editions of the neurology textbooks have deleted this test as such and consider them as obsolete. But what I would observe is this is more practicable and still a quite useful, simple method of confirmation of the carpal tunnel syndrome. Then the Phalanx sign is another more popularly done test. Of course, we have discussed this phalane sign in the beginning when we discussed about certain specific signs also. The method of eliciting is you ask the patient to have a full flexion of the hands and joint together. During this, the patient would have a pain of in the median nerve area, median nerve distribution area, the same graph which I showed you. And if the patient can hold it for around 60 seconds, it's not carpal tunnel syndrome. So patient cannot hold this because of the pain, it's not. And as per the test is about 80% specificity, but sensitivity is lesser. You may miss some of the cases. What I have observed is this symptom is quite difficult to elicit in older patients. Even otherwise, in older patients, they may not be able to flex the hand to that 90 degrees fully and forget about the keeping it for 60 seconds. So most of the times this phalane sign becomes somewhat impractical in old age patients, but in young patients this is one of the reliable tests. Then another of the tests is what we call as a carpal compression test, where you put a firm pressure directly over the carpal tunnel for about 30 seconds, and the patient may have the symptoms of pain and numbness over the area. It's just tunnel sign. In the tunnel sign, you tap over the area, but compression test, you press for 30 seconds and you elicit that. And this is considered to be one of a more specific test, where the specificity is considered to be around 96% and sensitivity is around 89%. So more reliable test is supposed to be there, simple clinical test. Then to identify those who have a tendency for the genetic tendencies, it's also called as a square wrist sign, where you assess the size of the wrist, ratio of the wrist to the thickness. So usually the ratio of the wrist thickness to the wrist width is greater than 0.7 in patients, then you call it as a square wrist. The thickness of the ratio, if this is more, then it's called as a square wrist. And such patients who have a higher thickness at the wrist area, they are supposed to have a high risk of carpal tunnel syndrome, which even suggests about the genetic tendencies also. And this test is supposed to have a 70% sensitivity. Then the other method is what we call as a palpatory diagnosis, where you assess the range of movements keeping the hand over the area. So with the hand, you just extend and flex the hand completely wrist area. The range of movement would be reduced in case of carpal tunnel syndrome. Of course, it can be reduced in many other conditions too, and hence the specificity is lesser, 75%. Whereas sensitivity, of course, it is true that the patient should have a pain or reduced range of movements when you press upon the soft tissues of the hand, and then either extension and the flexion is done, then you will have these symptoms as such. The confirmatory test for carpal tunnel syndrome is the electrophysiological study, where EMG is confirms about the delay in conduction of the impulses, as well as the severity also can be confirmed by the delay. The signals would be flowing through very slowly, and that confirms the carpal tunnel syndrome as the diagnosis. So reliable investigation to confirm carpal tunnel syndrome is mainly the electromyogram as such, or the electrophysiological studies. Treatment, now the basic treatments would be, in the early stages, suggested treatment is restriction of exercise, shortwave diathermy of stimulation are suggested. Another is about the wrist splints. Using of the wrist splints, there are different sorts of the wrist splints are used. One of the wrist splint which will be quite beneficial, which gives significant comfort to the patient, is where the hand is slightly kept in extended position, something around 20 to 25 degrees extended position as such. Another medical treatment which is often tried as a standard treatment is the steroid injection. But the ultimate is the surgical treatment. Surgical treatment is considered as the ultimate. As far as my clinical experience is concerned, when the patient present with the sensory symptoms in the early stage, and which is more common, we see more patients in that early stage, I would be preferring Kaishara Gugul Mrityunjaya Sarishta, because I would consider that as the ANA stage, where the patient would have only sensory pathology and the other tests are positive. And the patient should respond well to Kaishara Mrityunjaya Amritsarista or Ksharabasti or Agni Chikitsa in extreme severe cases. Rarely we do go for that Ksharabasti. Majority of the patients would be, you can manage only with the internal medications. When the patient has motor signs like there is a atrophy, then the prognosis becomes poor, outcome will be poor. But at that time, my prescription would be Chandraprabha Ekanvira Sugar Barista or again rare cases Apanabasti, Raleigh Apanabasti would be the prescription as such. Because carpal tunnel syndrome is one of the very common disease and quite coming to our clinic practice, and because of that there is a huge guideline given to the management of carpal tunnel syndrome is quite huge. There are around 30 to 40 guidelines in that. I have selected a few important sections of the guideline, copied as such, just to give you an idea like how the issue is handled in the current practice and what the guidelines would say. Majority of the orthopedicians, they do not follow the guideline, and there is a lot of confusing issue about that. The standard guidelines, selected guidelines, I am saying about this, I selected 5 guidelines which give you that clarity. I have just copied it as such. The following factors are associated with the increased risk of developing carpal tunnel syndrome, like premenopausal, risk ratio index, the same which I said, rheumatoid arthritis, psychosocial factors, that's also another of the important, and distal upper extremity tendinopathies, gardening, these are the established known conditions which is added in the new guideline. Then physical activity or exercise is associated with the decreased risk of developing carpal tunnel syndrome. A regular physical activity or regular exercise can prevent or reduce the risk of carpal tunnel syndrome. Use of immobilization like brace or splint should improve patients with the reported outcomes. So immobilization with brace or splint is one of the more reliable treatment. This is important. There is no benefit to oral carpal tunnel syndrome treatments like diuretics, gabapentin, astaxanthin capsules, which are non-steroidal anti-inflammatory drugs, or pyridoxine, which are commonly prescribed. And almost every patient of carpal tunnel syndrome going to a contemporary practitioner will be having any of these prescriptions, and it's now known that there is no benefit at all. Whereas surgical treatment of carpal syndrome should have a more benefit. It's definitely more beneficial in the patients where the symptoms are quite severe, and it should be seen, the benefit should be seen within 6 to 12 months in comparison to splinting. And this is about certain of the important issues. So that's about the carpal tunnel syndrome. Because we are discussing about the carpal tunnel syndrome, I will be referring to another of the issue, acute compartment syndrome. Of course, this is not a primary neurological pathology. It's something around a complex issue, but one of the manifestations of the compartment, this compression of the structures in the body due to physiological entities, and it's related to that because carpal tunnel syndrome also is a compartment syndrome, but carpal tunnel syndrome is a chronic effect of the compartment effect, the pressure effect, whereas a similar but variant pathology could be acute compartment syndrome. Of course, conditions which we see in the routine clinical practice are lesser, but whenever you see them, they are quite important. That's all the point. The acute compartment syndrome usually occurs due to the increased tissue pressure, and particularly the perfusion pressure is increased. If the tissue compartment pressure is more than the perfusion pressure, the blood flow would be reduced, and that results in what we call as acute compartment syndrome. And it also produces ischemia of the nerves and muscles. It's both myoneural muscles and the nerves which are affected quite frequently. There are two types. One, the fracture-induced syndromes, trauma-induced syndromes. Then the other is exertional compartment syndrome, which is associated with repetitive loading, and microtrauma are related to physical activity, continuous activity over the area or stress on the areas. The common areas, locations are the lower leg, forearm, wrist and hand. Rarely, acute infective pathology also can produce a compartment syndrome like myositis. Now, what I mean by that tissue perfusion pressure is the tissue perfusion pressure is a capillary perfusion pressure and the interstitial pressure, they are different. And the normal capillary perfusion pressure is considered to be around 25 to 27 millimeters of mercury. Interstitial pressure is around 4 to 6 millimeters of mercury, and hence the tissue perfusion pressure is something around 20 to 22 millimeters of mercury. That's which is required, and at that level the perfusion can be maintained, the tissue can have proper health. The causes, other causes for the acute compartment syndrome could be intensive muscle use. If the muscles are contracted very frequently and quite a long time with heavy load, or like a vigorous exercise, or when the muscles are contracted very powerfully as in seizures or tetany, it can produce a rupture of the microvessels, and that can produce a spasm. We see often patients with the seizures, epileptic seizures. After the seizures, they may develop a swelling in some areas of the body, either in the hands or in the legs, with painful conditions. That's a possibility due to the acute compartment syndrome. Or maybe those persons who do a lot of exercise, particularly stationary bicycle exercise, where the load is not varying, or horseback riding, etc., it can occur. Burn patients, it can occur. Another common incidence of the acute compartment syndrome is a snake bites, envenomation, when the venom enters into the body, and as a result of the snake bite, particularly the vipers, the hemolytic snake bites, they produce the compartment syndrome, swelling there, which is one of the common complications. Patients with having osmolarity of the plasma reduced, protein hypoproteinemia or nephrotic syndrome, there can occur. Hemorrhage due to injury, any sort of injury, or a patient where the patient is recovering from ischemia. After the ischemia, then there would be a huge swelling that also can produce the same. Drug or alcohol induced pathology, or patients who are unconscious, coma, or maybe where the skeletal muscles are destroyed, rhabdomyolysis, like statin poisoning or statin toxicity, not poisoning, I should not use the word poisoning, statin toxicity also can result in acute compartment syndrome, of course not so very common, rare as such. Or trauma, particularly gastrocnemius or peroneus muscle tear in the lower extremity, ruptured Baker's cyst, which also is common in patients of osteoarthritis, chronic old-aged patients, it can occur. Myositis, influenza-like conditions, autoimmune vasculitis, or patients who have androgen abuse. Androgen abuse is unnecessary consumption of the androgen, often used as a sexual stimulant, or patients of deep vein thrombosis also can present with the compartment syndrome. Symptoms of compartment syndrome are acute pain, which is much more proportionate to the trauma. So huge swelling over the area compared to the normal side, you can make out that. And particularly the swelling is at the area where the muscles are there. Severe edema is one of the features, or signs of ischemia in the distal area. These are the signs of compartment syndrome, acute compartment syndrome. This is quite important in any patients of trauma. Any patients of trauma, when you examine, you have to maybe cautious about the compartment syndrome in such patients, where the pain would be much more than what you expect due to the injury. And patients, if they have a fracture, the chances of compartment syndrome are quite high. Management, actually surgery is the only definitive therapy as such from the standard practice as such, but particularly if the pressure is more than 30 millimeters of mercury, compartment pressure is more than 30 millimeters of mercury, in such conditions it has to be emergency, otherwise it can result in necrosis of the limb, and amputation, it may result in amputation. The treatment is a fasciotomy. The fascia has to be opened and the pressure that has to be released, the secretions have to be released. The other important precautions, like do not elevate the limbs. If the patient is on casts or bandages which are tied around the area, release that, which can reduce the symptoms significantly. One of the most reliable treatment in compartment syndromes of this sort, but moderate at least, though not very severe, is a Gokshiradi Punarna Mandula Maharasnadi Kwata, which I do use in majority of the patients. That's about the compartment syndrome. With this, we will conclude today. We will continue in the next session about the other symptoms like Guillain-Barré syndrome and so on. So if there are any questions, we will try to answer and then continue. stop at this level. Okay, there are no questions, so we'll end up today.
Thank you, sir.